Imagine this. You or someone you love had a stroke a few years ago. It was a terrifying experience. But you put in those grueling hours of physical therapy.
Right, the really intense rehab,
Exactly. You rewired your brain, and you made a full recovery. I mean, you got your life back.
which is an incredible milestone.
It is. But then you wake up one random Tuesday morning.
Yeah.
You try to speak, but your words are thick and slurred. You look in the mirror, and one side of your face is drooping.
Oh, wow.
Yeah. You try to lift your arm, and the weakness is undeniable. It is literally the exact same nightmare all over again.
That is just, I mean, it's completely devastating for a patient.
So you rush to the emergency room, the stroke clock is ticking, the neurologists are moving fast. But then, after a barrage of imaging, they tell you something completely unexpected. You aren't having a stroke at all.
It's a profound shock to the system, for a patient to process that.
I can imagine.
Because you're experiencing all the visible hallmarks of an acute ischemic event. The physical deficits are very real, but the underlying pathology happening inside your skull is entirely different.
Well, welcome to today's deep dive. We are exploring the really complex and, honestly, often misunderstood world of stroke mimics.
Specifically zooming in on a phenomenon known as post-stroke recrudescence, or PSR.
BSR. We've pulled together a stack of clinical reports, case control studies, and neurovascular journals to map out exactly what is happening in the brain during these phantom strikes.
There is some fascinating data in there.
And the through line for our conversation today, our main focus, is the healing duration. We are going to examine how long these episodes last, why they vanish, and what actually dictates the timeline of recovery.
Because understanding that timeline completely changes how you view the condition.
It really does. But to get to that timeline, we first have to understand the physical reality of the brain during an episode.
Yeah, and the scale of this issue in emergency medicine is just staggering. When you look at the data for patients rushing to the hospital with suspected stroke symptoms, mimics account for a massive portion of those admissions.
Like, how massive are we talking?
Well, some studies put it at 30%, and others suggest nearly half of all suspected strokes turn out to be mimics.
Wait, nearly half. That's wild.
It's a huge operational burden.
So within that massive category of mimics, we have PSR. And the defining characteristic of post-stroke recrudescence is the temporary worsening or reappearance of previously resolved neurological deficits from a past stroke.
Right. The critical distinction in the literature being that PSR is not a relapse.
Meaning no new damage?
Exactly. A relapse involves a new vascular event, so new clot, new hemorrhage, new tissue necrosis. But with PSR, the imaging shows no new structural damage whatsoever.
It's strictly a reactivation of old symptoms. And the demographics here are pretty fascinating. The data shows this typically occurs around 3.9 years after the initial stroke.
But roughly 4 years out.
Yeah. And it disproportionately affects women, who make up about 62.1% of cases. It also correlates really heavily with risk factors like diabetes, dyslipidemia, smoking, and advanced age.
Which is key, right? Those demographic markers give us a vital clue about the vascular baseline of these patients.
Oh, so?
Well, if you have a history of dyslipidemia or diabetes, your overall vascular health is already managing chronic stress. When you suffer an initial stroke, your brain relies on neuroplasticity to heal.
Right, building new pathways.
Exactly. It builds new compensatory neural networks to essentially bypass the dead tissue. It's an incredible feat of biology, but those new pathways are built on precarious scaffolding.
Oh, I see.
They are functional, but they just lack the robust resilience of your original neural architecture.
So if I'm conceptualizing this, it's very similar to an old sports injury. Say you completely tore your knee cartilage years ago.
Oh, yeah, that's a good comparison.
You had the surgery, you did the rehab, you run marathons now, but then a storm rolls in, the barometric pressure drops, and suddenly you are limping because the old injury site is flaring up.
That is precisely it. PSR is essentially that same mechanism, just localized to the neural pathways of the brain.
So the brain retains that structural vulnerability.
The structural vulnerability is the core of the issue here. The brain retains that old infarct zone, and while the patient has functionally recovered, that specific territory remains permanently altered at a cellular level.
It's like the weak link in the chain.
Exactly. And just as the barometric pressure irritates the old knee injury, specific systemic physiological stressors act as the irritant for that old brain lesion, causing the network to temporarily fail.
Which brings us to the triggers. If there is no new blockage starving the brain of oxygen, what is the stressor causing a flare-up 4 years down the line?
The clinical literature points to systemic infections as the overwhelming culprit.
Yeah, they account for over 52% of PSR episodes. Urinary tract infections alone make up 30.8%, and pneumonia accounts for another 21.5%.
It's mostly infections, but not exclusively.
Right. You also have metabolic factors driving about 37% of cases. That's heavily led by hyponatremia, or low sodium, at 18.5%. And the rest are triggered by things like hypotension, severe insomnia, high stress, or even benzodiazepine use.
And the diversity of those triggers is what makes this so incredibly complex to diagnose clinically.
They're all over the place.
Exactly. You have bacterial, metabolic, and pharmacological stressors, all producing the exact same focal neurological deficit.
But if you're listening to this and mapping out the logic, there is a glaring question here. A UTI is a systemic infection in your bladder or kidneys, right?
Right.
And hyponatremia affects your entire bloodstream.
Okay.
If the stressor is systemic, why does it only shut down the exact same hyperspecific neural pathway that was damaged 4 years ago?
That's the million-dollar question.
Like, why does your arm go weak instead of your whole body just feeling the effects of an infection?
To understand that, we really have to look at the compromised integrity of the blood-brain barrier at the site of the old injury.
Okay, break that down for me.
So when you develop a systemic infection like a UTI, your immune system releases pro-inflammatory cytokines into the bloodstream to fight it.
Right, basic immune response.
Yeah. And under normal circumstances, the blood-brain barrier keeps those immune mediators from flooding into your central nervous system. But the chronic infarct zone in your brain, that old stroke scar, has abnormal vascular beds.
Oh, I see.
The endothelial permeability is permanently altered there.
So the blood-brain barrier is fundamentally leaky at that one specific microscopic location.
It is a totally compromised border.
Yeah.
Those circulating inflammatory cytokines essentially find the crack in the armor.
Wow.
They selectively infiltrate the perilesional zone, which is the tissue immediately surrounding the old scar.
And what happens when they get in?
Once those cytokines cross over, they trigger a localized inflammatory cascade that disrupts synaptic transmission and axonal conduction. It basically short-circuits the local wiring without inducing any actual cell death.
Okay, that explains the infectious triggers perfectly.
Yeah.
But what about the metabolic trigger?
That's a bit different.
Because if a patient presents with hyponatremia, they don't have that same immune cytokine storm. So how does a drop in sodium selectively target the old injury site?
The mechanism shifts there from an inflammatory disruption to a purely electrical one.
Electrical.
Yeah, neurons rely on a strict concentration gradient of sodium and potassium to generate action potentials.
To actually fire and send signals.
Exactly. When extracellular sodium levels drop across the entire body due to hyponatremia, every neuron in your brain experiences that deficit.
Okay, so why doesn't the whole brain shut down?
Because the healthy neurons in undamaged territories have enough metabolic reserve capacity to maintain their action potentials despite the suboptimal sodium levels.
But the perilesional neurons don't have that luxury. They're already metabolically fragile just by virtue of surviving the initial stroke.
You nailed it. They are operating at the absolute limit of their resources. When the sodium gradient drops, those specific weakened neurons cross the threshold of failure.
They just can't keep up.
They can no longer depolarize and fire. The pathway goes dark, and the patient suddenly loses the ability to move their arm or form a word, mirroring the original stroke presentation perfectly.
Which is just, it's terrifying in the moment. But since the brain is just experiencing this temporary localized failure driven by a systemic trigger, that completely changes the calculus of recovery.
Absolutely.
The most pressing question for the patient sitting in the emergency room is the healing duration. And the data here is incredibly optimistic.
It's one of the few silver linings in neurovascular emergencies.
The healing duration of PSR is entirely distinct from acute stroke recovery. By clinical definition, a true PSR episode results in the patient returning entirely to their pre-presentation baseline on the modified Rankin scale.
And just for context, the modified Rankin scale is our standard for measuring neurological disability.
Right.
With a true mimic, we expect a complete reversion of these new deficits. The patient doesn't just make incremental improvements. They go all the way back to their functional status from the day prior.
And the speed of that regression is the most striking part of the data. The mean duration of a PSR episode is just 18.4 hours.
Less than a day.
Less than a day. A staggering 69.5% of cases completely resolve within the first 24 hours of admission. Another 17.5% resolve on day 2, 6.1% on day 3, and only 6.9% extend to day 4 or beyond.
The psychological relief that timeline provides cannot be overstated. I mean, transitioning a patient's mindset from anticipating months of grueling neurological rehab to, anticipating a discharge the next morning,
It's a profound shift.
completely profound.
But those rapid statistics come with a massive caveat, which is really the foundational rule of healing for stroke mimics. The timeline of the phantom stroke is inextricably handcuffed to the timeline of the trigger.
Yes, that is the golden rule here.
The focal deficits do not spontaneously resolve on their own. They only regress once the systemic stressor is neutralized. Correct the hyponatremia, and the arm weakness vanishes. Administer antibiotics for the UTI, and the facial droop resolves.
The resolution of the mimic is a direct reflection of the resolution of the underlying physiological stress.
Which makes sense.
It does. And when that systemic stressor is complicated or resistant to treatment, the healing duration of the mimic extends accordingly.
There is a brilliant case study from the Turkish Journal of Neurology that perfectly illustrates this dynamic.
Oh, I know the one you're talking about.
It's fascinating. The researchers detailed the case of a 7-year-old woman with a history of stroke who presented to the emergency neurology clinic with sudden facial paralysis and an ataxic gait. She was completely unable to walk steadily.
It looked like a textbook acute vascular event.
Right, but her clinical workup revealed a very different trigger. She didn't have a simple, easily reversible issue like a UTI or mild dehydration. Her stressor was Ramsay-Hunt syndrome.
Which involves the reactivation of the varicella-zoster virus, the shingles virus, specifically affecting the facial nerve near the ear.
Which is an incredibly painful and aggressive viral outbreak. It's not something you cure with a 24-hour IV drip.
No, absolutely not. Treating the varicella-zoster virus in that specific ganglion requires a really prolonged, intensive therapeutic approach.
What do they have to do?
She was placed on heavy antiviral therapy with valacyclovir and a strict regimen of corticosteroids. Because her stroke symptoms were anchored to this viral trigger, her healing duration completely defied that 18.4-hour average.
There wasn't an overnight fix.
Not at all. It took 1 full month of continuous antiviral therapy for the shingles to recede. And in lockstep, it took 1 full month for her facial paralysis and ataxic gait to completely regress.
That 1.1 correlation is just, it's fascinating. The brain isn't broken. It is just sounding a localized alarm that persists for the exact duration of the systemic fire.
That's a great way to put it.
But this raises a massive clinical dilemma. If healing is ultimately about neutralizing the trigger, why is PSR such a burden on emergency departments?
Because of the initial presentation.
The reality is in the first hour a patient arrives, an ER physician cannot easily tell a mimic from a real stroke.
The diagnostic pressure in that first hour is immense because the physicians are fighting the stroke clock. For an actual acute ischemic stroke, time is brain tissue.
They can't just wait and see if it heals in 18 hours.
Right. The gold standard intervention is intravenous thrombolysis TPA, but the therapeutic window for TPA is incredibly narrow. It's typically capped at 4.5 hours from the onset of symptoms, and its efficacy decreases with every passing minute.
So you have a patient with slurred speech and a drooping face, the clock is ticking, and the doctor has to make a call before the window closes. If they administer a powerful clot buster to someone who doesn't actually have a clot, the consequences seem incredibly risky.
And the misdiagnosis rate reflects that pressure. Studies indicate that up to 15% of patients who receive TPA are actually experiencing stroke mimics.
Wow, 15%. Is that dangerous for the mimic patients?
Clinically, administering TPA to a mimic patient is generally deemed safe. The rates of symptomatic intracranial hemorrhage are very low.
Okay, that's a relief.
However, it exposes the patient to an entirely unnecessary intensive care protocol. They endure strict ICU monitoring, an extended hospital stay, and massive financial burdens.
How much are we talking?
An average stroke hospitalization involving TPA and ICU care easily exceeds $20,000.
Contrast that with the cost of a definitive diagnostic tool, like a diffusion-weighted MRI, which runs between $3,000 and $11,000.
Exactly.
But you can't just throw every patient in the MRI immediately, because acquiring those images eats up precious time on the stroke clock. If it is a real clot, waiting for the MRI allows millions of neurons to die.
That is the crux of the clinical puzzle. To navigate this, the medical community relies on a strict 5-point diagnostic criteria for PSR to guide these rapid decisions.
Walk us through those 5 points.
First, there must be a transient worsening of residual post-stroke deficits. Second, brain imaging must confirm signs of a chronic old stroke.
Right.
Third, and this is the definitive marker, there must be no acute new lesion visible on diffusion-weighted MRI.
Meaning no fresh damage.
Exactly. Fourth, a new cerebral ischemia must be considered clinically unlikely based on the specific pattern of symptoms. And fifth, physicians must definitively exclude seizures, often using an EEG,
Why seizures?
because post-stroke epilepsy can perfectly mimic these exact same deficits.
Ah, okay. But because the MRI is the definitive tiebreaker but costs time, the physician's ability to take a granular patient history becomes their most vital tool.
It really is.
They have to play detective while the stroke clock is running. They can't just evaluate the motor deficits. They have to aggressively hunt for the trigger. Asking about recent fevers, changes in urination, new medications, or sleep disruptions.
That clinical history often holds the key.
Pinpointing that underlying stressor early is the only way to confidently pivot a patient away from a $20,000 ICU admission and toward a targeted, trigger-specific treatment plan.
But gathering it accurately during a neurological emergency, when the patient might be aphasic or highly anxious, it requires exceptional clinical acumen.
It is a remarkable intersection of neurobiology and emergency medicine. What the literature ultimately reveals is that stroke mimics, specifically post-stroke recrudescence, are a terrifying clinical presentation wrapped in a profoundly optimistic physiological reality.
I agree completely.
The healing duration is remarkably fast, often resolving in under a day, provided the underlying trigger is identified and neutralized. If you are navigating life after a stroke and these old symptoms suddenly reemerge, it's a medical emergency that requires immediate evaluation, but the data offers a powerful reassurance.
It does.
Your brain might just be utilizing its most vulnerable pathway to signal a completely separate, highly treatable systemic issue.
The clinical optimism surrounding a single episode of PSR is very well supported by the data. The rapid return to baseline is the expected outcome.
Right.
However, there is a critical gap in the current neurovascular literature that warrants deeper investigation.
What's the blind spot?
We understand the mechanics of a single isolated mimic, but we must consider the cumulative impact of these events over time. What happens to the paralesional tissue if a patient experiences frequent, recurrent systemic infections?
Oh, wow. I had thought that.
The concern is that these repeated, localized inflammatory cytokine attacks on a chronically injured brain might not be entirely benign over the course of decades.
So it could be doing unseen damage.
Researchers are currently exploring whether frequent PSR episodes might silently accelerate localized neurodegenerative processes. It could potentially act as a precursor to post-stroke cognitive impairment or vascular dementia.
That is a sobering thought.
The field is actively working to answer this, serving as a reminder that while the brain's capacity for healing is extraordinary, it is an organ that fundamentally remembers every insult it endures.
That is all the time we have for this deep dive. Keep asking questions, keep exploring the research, and we will catch you next time.